Good morning, everybody who's gathered here for the LACNETS conference. I am Chandrasekharan. I'm a medical oncologist at University of Iowa. I've been taking care of patients with NET diagnosis for the past 8 years here, and I hope to cover this topic of first to know about your NET diagnosis and start from the basics of what you need to know, what's the workup you need when you're told you have a cancer or neuroendocrine tumor. So you're told you have a neuroendocrine tumor. What are the next steps? And like any patient who's being told who's got cancer, it's like a big world out there trying to navigate. So I hope to cover some basic things that you need to know. First thing, I think every patient, every person who's diagnosed with any cancer, including neuroendocrine tumor, needs to educate themselves. This helps you empower yourself so that you could advocate for yourself. And these are, I think, the very basic things that you need to remember. It's okay to do all these things. Patients are afraid to ask questions. Patients are afraid to ask if this is okay or that is okay. But remember, this is about you. So educate yourself, empower yourself, and advocate for self. It is okay to consider an opinion with a NET specialist. This is, though it's increasing in incidence, still technically a rare cancer. Even a very busy practice may not see as many patients with neuroendocrine tumor. So it's okay to ask to be referred to a center that has high volume of neuroendocrine tumor patients. And it's important to also remember that every patient needs an individualized plan. You may interact with your peers, you may interact with other patients who are going through the similar journey, but it's actually not the same journey. It's about you again. And so every patient needs an individualized plan and no one size fits all approach for this particular cancer. So it's also important to remember this is about shared decision making. So this is not about the doctor giving you a prescription and saying, this is the plan, this is what we're going to carry out. I think we are here also, of course, to provide input for a good plan or based on what we think medically is a good next step. But it's about decision making along with you, along with the patients, along with the caregivers. So this is important. I think as we talk about all the other basics, come back to this. Remember, this is going to help you through the journey. Now, when some basic things I want to cover, everybody may not have the luxury of living in a town with easy access to a high volume center, but it's still okay. It's still important to try to get some things done if possible. So request a pathology second opinion if unable to go in person to see a NET center. And this is because, oncologists are blind without a pathologist opinion, and it's very, very key. For example, at University of Iowa, we have an expert pathologist, and we get pathology second opinions in addition to patient second opinions. At least 10% of pathology or 15% roughly of the diagnosis is revised, or we add some nuances to the diagnosis that could impact the patient's care. So pathology second opinion, if at least possible to go in person for a second opinion from a NET center. It's also important to get imaging at a very good center because it makes a huge difference when we are assessing these tumors and monitoring these tumors. I'm going to show you an example of a CT scan that was done in a center that does not have a neuroendocrine tumor protocol. This is basically what we call a contrast CT. That is, on the white stuff that you're seeing here is the liver on the left side, and the black big ugly patches you're seeing is tumor. Now, the same person within the week had another scan at a neuroendocrine tumor center, and this on the other side is an arterial phase imaging. This is basically you give a dye to the patient, take a CT scan when the blood vessels or the arteries are being filled with the dye, and then you take another picture when the dye is being washed out, what we call a venous phase. So the same tumors you can see show up very well in an arterial phase imaging on this side. So the same patient, literally the scan was done within a week in two different places, one with the neuroendocrine tumor protocol. And these are big tumors, so they could be seen easily on the what I would call an inferior or different protocol CT as well. But imagine small tumors. If you don't get a CT with the right contrast at the right place, you may not be able to assess your disease correctly. Now, even if an MRI is done, which is a little bit more reproducible, it's important to look for what we preferably call diffusion weighted images, this type of a sequence we do in MRI, so that can bring out neuroendocrine tumors very well, especially in the liver. So it's important to consider also imaging at a good center. Now, if newly diagnosed, you need to have at least one time a baseline PET CT, specifically copper PET CT and a gallium PET CT, which is helpful to know if the tumors have what we call Octreotide receptors. I'll kind of go over the details of this later, but this is the basic as soon as you're diagnosed to remember to ask. And then also it's important to consider an opinion at least at some point with a high volume expert or he or she has a good team to back up your plan. Does expertise in this cancer matter? Now, this is just an example of one study. They looked at 900 plus patients in what we call a SEER database. A SEER database is like a registry where a lot of outcomes patients with different cancers have certain elements put in. And researchers can look at many factors as to the type of diagnosis and outcomes, survivals. Some ways it's crude, we can't get to the details, but it's an often used research tool. So what you see here in the green is the high volume center. Now they use some definitions of how many patients the particular cancer center saw with patients with neuroendocrine tumor. And based on that, they ranked it as high, medium, and low volume. And this is just a summary of the disease-free survival. So how long do the patients live with cancer-free post-surgery or some other intervention? You can see on the green curve on the top, patients who went to a high volume center seem to have done better than the blue curve, which is at the bottom, which was considered a low volume center. The study has a lot of bias and a lot of things that we can adjust in real world, but just demonstrate the points that patients with neuroendocrine tumor, it is definitely helpful to seek an opinion at a high volume center at some point in the course of their journey to make sure they have a good plan in place. So I call this my NET framework. This is the elements of cancer that I look at before making any decision plan, any type of treatment plan. And this is not just the one time at the diagnosis. This is important every time when we make any type of treatment decisions, any type of surveillance plan. So this obviously includes factors related to the cancer itself, the tumor itself, as well as factors related to the patients, like the patient's health situation, their values and preferences. Every oncologist or every person taking care of a patient with this cancer has maybe a different framework, but these are probably some common elements in that. So let's talk about the stage of the cancer. A lot of patients confuse a stage with a grade. No, every cancer is staged. Staging refers to, is the cancer confined to the origin, like where it started, or has it spread to another place? So in neuroendocrine tumors, we still use the stage called 1, 2, 3, and 4, like other cancers. Unfortunately, the reality is majority of the patients, I would say 90% or 95% of the patients we see in our practice are often advanced or stage 4 by the time they're diagnosed or come to a doctor. Most common site of spread being the liver. So the word we use for that situation is metastatic disease. So majority do have metastatic disease at presentation in neuroendocrine tumors. Now, sometimes the cancer can be detected incidentally. Somebody had a scan, let's say for a kidney stone, they found a lymph node in the belly that raises a suspicion of a neuroendocrine tumor in the small bowel, or somebody had a scan for something else, and then there was a mass in the pancreas and the biopsy then showed it to be neuroendocrine tumor without a spread. So those situations do happen. Or for example, a colonoscopy is done and a small polyp is found in the rectum that has a neuroendocrine tumor. So these are situations where we do occasionally encounter what we call a locally advanced, a tumor that has not spread. Now, focusing on the small bowel pancreatic, not on all types of neuroendocrine tumor, but when it's locally advanced, meaning it's not spread to another organ, then the treatment's intention is to cure the patient. And often surgery is the best way to do it as long as the patient is healthy enough to undergo surgery. So if it's just a small bowel neuroendocrine tumor with the lymph nodes in the mesentery is like the belly fat in your body, which is often the first site where we see these tumors, then that can be removed surgically and hopefully with cure. Now, one thing to remember when patients are told they are cured with this cancer or what surgery you had was for curative intent, you need follow-up for a very long time. Other cancers like colon cancer, say, or lung cancer, sometimes we follow patients for about 5 years roughly, and often the incidence of cancer recurring after that is very low. But neuroendocrine tumors, because they're indolent and slow growing, at the very minimum, we talk about 10 years of follow-up after a curative intent surgery. And sometimes I would say even lifelong. And whether we do scans or other kind of monitoring is still one of those areas of interest for doctors. Metastatic disease, as I mentioned, refers to a spread to another organ. Let's say the cancer started in the abdomen, in the small bowel, but it's already in the liver or the lymph nodes beyond the first site of spread. Or say in the neck, that's a different site from the abdomen. So that's what we refer to as a non-regional lymph node, meaning outside the first step of spread in a lymph node is non-regional lymph node. Or peritoneum, which is a common site of spread for neuroendocrine tumors in the gut, in the small bowel, or the pancreas, is basically the belly cavity, or the fat within the belly cavity is referred to as peritoneum. So these are some common sites of spread in neuroendocrine tumor. It's very rare for these cancers to go to the brain. It is possible for them to spread to the bone as well. So whenever the cancer is spread, we refer to that as metastatic disease or a stage 4 cancer. Stage 4 cancer, by definition, is not curable but very much treatable. Patients with neuroendocrine tumor, especially the low grade, can live for years and decades with a stage 4 neuroendocrine tumor on therapy or sometimes off of therapy, depending on the situation. So, but knowing the stage is important so you know the intention of our treatment. Now, knowing the tumor grade and differentiation is probably the next biggest thing. This is the latest classification, what we call the 2019 classification of how doctors look at neuroendocrine tumors. Some of the words that may be new to some of the patients with a new diagnosis is the grade and differentiation. So what are we referring to? We like to put the tumors into many buckets, grade 1, 2, and 3. That's kind of a broad classification. And this is really helping us know how likely is the cancer growing, or how fast is the cancer likely to grow based on that. And the differentiation I tell patients is just kind of looking at the microscope to say how organized are the cancer cells in comparison to a normal tissue. So something that's still somewhat organized is a well-differentiated cancer, versus something that's very chaotic, very fast proliferation, we refer to as a poorly differentiated cancer. Just for the classification again, whenever it is poorly differentiated, sometimes the word small cell or large cell is used with it. Now, these are also sometimes referred to NEC, as you can see on the left there on the table 2. That is basically a neuroendocrine carcinoma. Now, these patients have a very different prognosis. These tumors have very fast proliferation. They need chemotherapy. The role of surgery is controversial. The other treatment options we use in the grade 1, grade 2, like the slow-growing neuroendocrine tumors like PRRT or the drug therapies, have limited utility in this high-grade poorly differentiated carcinomas. I will show you slides on how it looks under the microscope and come back to this. So this is an example of what a grade 1 or grade 2 or small cell or cell looks like. The pink and purple is basically how tumors look under the microscope. Our pathologists look at it and do some additional stains on the tumor to help us classify that. So the first picture on the left side, the panel A, that shows is a well-differentiated neuroendocrine tumor. You see those blue cells clustered together, the pink there, they form these circles like glands, so it's kind of still organized. So that is a well-differentiated neuroendocrine tumor. The panel below that in C on the left side is also a well-differentiated neuroendocrine tumor, still somewhat organized. But on the right side that you see these A, D, and A, the 3 panels on that, you can see there are a lot of cells. You don't see those round structures like glands. There's a lot of cells in there. So that's a high proliferation tumor. Now back to the left side where I have labeled it as grade 1. What is that looking at? So you may hear the word Ki67, which is basically a stain a pathologist uses to see how many cells are dividing within the tumor. And they classify that and express it as a percentage. So it is brown in color, the stain here. So you see on the first left side, the grade 1, you barely see a brown dot on the blue background. So there are barely any cells dividing what would be a grade 1 tumor. So for example, if less than 3 cells are dividing, so here I talked to you about how the Ki67 here on the left, you can see less than 3% is a grade 1 well-differentiated neuroendocrine tumor. So if that proliferation is between 3 and 20%, then it's a grade 2, and often it's a well-differentiated neuroendocrine tumor. So on this panel again, on the left side, you see the D that's labeled grade 2. You see those brown dots behind the background is the blue things. So yes, there are some cells dividing, that's what it means, but it's less than 20%. So that's grade 2. Now, on the right side now, the lowest panel where you see well-differentiated grade 3. Now, this is where the tumor seems to be still somewhat organized. You still see some cells that form glands, circles that look like good tissue. But on the brown stain, you see a lot of brown dots. That's a well-differentiated grade 3. So the percentage of proliferation here is almost like 35-40%. So though it's well-differentiated, it has a very high proliferation rate, or Ki67. So we call these tumors, this is kind of a new and evolving entity of well-differentiated grade 3 neuroendocrine tumors. Now back to this slide, on the top corner where it's labeled small cell and large cell, you see a lot of brown dots. On the panel B and E, right before them, you see there are multiple cells that are all dividing, and some cells on the top look small, so we refer to as small cell, On the bottom, the cells look larger, so we call it large cell. But essentially, these are poorly differentiated, very fast proliferating with almost like a Ki-67 of 90-80%. So these are the ugly cancers. We call them neuroendocrine carcinomas rather than neuroendocrine tumors that need chemotherapy right away. Now, this is the basics. The pathologist is where what I do in clinic depends on this. When I talk to a patient, I need to know the grade before we start talking about a treatment plan. So now there are some situations where there are other variables. For example, a lot of times there can be a mixture of cancers. So you could have a regular, what we call a plain old adenocarcinoma, basically like a regular colon cancer or a pancreas cancer, but they may have elements of neuroendocrine cancer cells. So for example, on the panel on the left side, B, you have the cancer cell staining for synaptophysin, like a protein that's positive in neuroendocrine tumors. On the panel D, this is actually a breast cancer, which has some neuroendocrine stains, but it's actually a breast cancer with neuroendocrine differentiation. Now, this is not neuroendocrine tumor. We don't use the same PRRT in treatments here. On the right side, you see a tumor in the colon that has two components. It has what we call the regular colon cancer, or what we refer to as an adenocarcinoma, which is staining in that D section that you see there in brown color. But on the lower E section where you have that panel labeled, there is one part of the tumor that's brown in color, which is actually the neuroendocrine component. So this tumor essentially is two parts mixed with adenocarcinoma and neuroendocrine tumors, what we sometimes refers to as MINEN these days, or mixed neuroendocrine, non-neuroendocrine tumors. Treatment of these is also different from the regular neuroendocrine. So this is where the pathologist is key, because we definitely see patients where it's being called as neuroendocrine cancer, but ultimately it ends up being a breast cancer with neuroendocrine differentiation or colon cancer with neuroendocrine differentiation. So that treatment is completely different. So pathologist is key. Next question, site of origin. Why does it matter? Where did it start in the pancreas? Did it start in the small bowel, in the lung, the rectum? Well, the treatment could differ based on that, because certain drugs we use in pancreatic neuroendocrine tumors do not work or have not been shown to have efficacy in small bowel neuroendocrine tumors. It also matters because they may be, for example, small bowel neuroendocrine tumors may be of a low grade, less responsive to chemotherapy. The receptor expression, what we call as octreotide receptors that I will cover later, may also differ based on the site of origin. We expect, or a majority of the grade 1, grade 2 small bowel neuroendocrine tumors, almost 95%, do have protein or octreotide receptor expression. Now, the least is probably lung. So if you have a lung neuroendocrine tumor, majority of those patients may not have the octreotide receptors on their surface, which means PRRT, which is like a treatment option that sometimes we consider, is not an option for that patient. So site of origin, knowing that helps. Also, it may help for choosing a drug. There are some drugs that we know work across all neuroendocrine tumors, no matter what the origin is. For example, Afinitor or everolimus, the same drug, that can be used whether it's a lung, small bowel, or pancreatic or unknown neuroendocrine tumor origin. It also could matter for symptoms. We know the type of symptoms certain hormones make come from certain origin. For example, a pancreas neuroendocrine tumor may secrete gastrin, which is a hormone that can have risk of ulcerations in your stomach or diarrhea. If it makes insulin, you may have low blood sugar. These are more likely to be of pancreatic origin. Small bowel neuroendocrine, typically those are the ones that have the diarrhea or the flushing episodes. Lung neuroendocrine tumors may also have the flushing and diarrhea sometimes, but flushing. So this is helpful to know the symptoms to kind of elucidate that. It may also help sometimes to make surgical plans. There's a lot more literature to do what we call debulking surgery, removing what we see in small bowel origin neuroendocrine tumors. Now, this is the algorithm that University of Iowa uses that I put out there. Now, I'm not saying this is what everybody should be using, but that's just as a framework. So when we get tissue, we stain it for certain proteins again and try to see even if on the imaging, which is like a scan or a gallium PET CT, if we can kind of clue in on one area. So if the tumor is CDX2 positive, which is a protein that's expressed often in a midgut neuroendocrine tumor, we may classify it more likely to be midgut. Now, if it's islet-1, which is a protein expressed in pancreatic neuroendocrine, that's likely a pancreatic. Another one that is not mentioned that you can see on the round 2 of stains is OTP positive. So that often tends to be a lung origin. Or if it is SATB2 positive, it could be a rectal neuroendocrine tumor. So again, sometimes we do all the stains and the pathologist may, this is more likely it. But if we don't see it on a CT or a gallium or endoscopy or rectal ultrasound, we've done all the workup and we still can't, yes, It may be one of those unknown origin on imaging, but sometimes the staining helps to know what option of therapy may be to choose. Now, the grade 3 neuroendocrine tumors, like I said, is an evolving category. As doctors, we are learning more about this patient population and how it behaves. And I think there's a lot left to be done in that group. Some of those tumors behave very indolently, very slowly, just like a grade 2, and some tend to be a little bit faster growing and behave a little bit more like those poorly differentiated carcinoma. So it's kind of like it's a continuum that we are trying to separate out. Some of the stains we do, which are again in some centers disputed, the literature or the research is still ongoing. We do test for a protein called RB. So if the RB is lost in the tumor that is a high grade tumor, they tend to behave more like a neuroendocrine carcinoma. If the RB is intact, they still may be somewhat of a slower growing grade 3 neuroendocrine tumor. Again, there's still some evidence and literature that's lacking in this area, but this is something that we are using in practice at University of Iowa right now. So sites of metastasis next. Where has the cancer spread? Because this is helpful to also make a treatment plan. If it's only in the liver, should we go for a surgical option? Should we go for embolization or histotripsy? Some patients are all excited about that option, or ablation, which is referring to like burning, microwaving a tumor from outside in some places when it's favorably located. Now, if you have a ton of cancer outside the liver, say in the bones, in the peritoneum, or very diffuse, maybe those limited surgical options may not be of great value. Maybe something that goes all over your body, like a drug therapy or PRRT, may be a good option. Peritoneal metastasis, which is again referring to the belly cavity spread. Now, again, as a surgical center, we do offer surgery also for some of those patients, but it also depends on how much is there. Can we achieve a good amount of cancer reduction by doing the surgeries? Should we be doing PRRT in those patients? Because there is some literature to suggest that when it's predominantly in the peritoneum or the belly cavity, PRRT may not be as effective as, say, in other locations. So these could help determine our next plan if there's growth or just up front. Also, it helps to determine a surveillance plans. For example, if I know a patient has at baseline a ton of disease cancer in the bone, sometimes CT scans and MRIs also may fall short of assessing the site of disease. So I may incorporate a gallium PET CT at some intervals to look at these sites and make a plan. It also helps us to be prepared for symptoms. If somebody has a peritoneal dominant disease, I would probably want to tell the patients, if they ask me what to worry about bowel obstructions or fluid in the belly. If it's a huge pancreatic mass that's eroding into the gut area, then I would tell them to be, just think about, could it be getting jaundice or could it be bleeding into the gut? So the location, or if it's in the bone, can it cause pain? Again, not every person who has cancer in the bone has pain, but if they do have pain, it's important to think, is their cancer contributing to the pain so that we can address it? So knowing the sites of disease is helpful for all symptom management as well as the treatment management. So that's why I say if you were recently diagnosed, you need to have at least a baseline, which is actually part of our guideline by multiple societies, to have a gallium or a copper PET CT to know the distribution of the disease, as well as to know the receptors if those octreotide receptors are present on the tumor. So in one day in clinic, I can see 3 patients like this. So this is a PET CT of 3 different patients. On the first panel, you see big kidney beans that you see. That's just the kidney. But all the extra black dots that are seen are all sorts of tumors mostly in the bones that you're seeing. There's very little in the liver, but it's a bone dominant disease. In that person, I may be considering gallium PET CTs at some frequent intervals to know what's happening there. On the middle panel, you see this big dot on the left side, which is actually in the liver. And that's just a single tumor in the liver. Lower down is the bladder in the black, and the right side is the spleen. So that's probably not something, related to the disease. On the right side, which is the last patient here, you see these tiny, tiny dots all over the liver. So same day in one clinic, you could have such different presentation, and these patients are going to need a different modality of surveillance maybe, or different plan for each one of them. So next thing we need to know about the tumor is octreotide receptor status. So if the tumor has receptors, what we call octreotide, another word sometimes we use is also called somatostatin receptors. We want to know if the tumor has that, whether it's present in all the tumors that you have. So let's say a patient has a CT scan that shows 10 spots in the CT scan. When I get a gallium PET CT, I want all those 10 spots, if they have receptors, to glow on the black or orange color in a PET CT. So on the left side bottom is the blue color, which is basically the cancer cell. And you see those orange color receptors. These are usually expressed on the surface of the tumor. And knowing that helps us to know whether we can treat those patients with PRRT, which is a treatment option for these patients. You see that green color arrow, which is basically the receptor. It sits on top of the receptor. That's the octreotide molecule. And the red bomb-like picture caricature there is actually the radioactive element, or in the case of neuroendocrine, often lutetium-177. Now, the key is you need to have those orange things on the cancer cell to deliver this drug there. So if you don't have the cancer cells, don't have the receptors, this is not a good modality of treatment. So on the two pictures you have are actually a CT scan, and right next to it a PET CT. On the CT scan, this big gray black dot that you're seeing on the left side within this liver is actually the cancer. But you see on the PET CT, you don't see the black color glow. This is the spleen and the bladder and the kidney, but you don't actually see the tumor lighting up there. So this is a huge tumor, but no receptors. And this patient, if we talk about PRRT, that's unlikely to be effective or even touch that tumor. So knowing the receptor status is helpful. Next is symptoms. Symptoms can be either just because of where the tumor is located or the bulk of the tumor. If the entire tumor, entire liver is full of tumor, or a big chunk of your liver is by the tumor, or the bone is involved extensively, like one of those scans, or it can be because of the hormones that the tumor is secreting. Now, the most important thing is quality of life. How is this cancer affecting the patient? That's important to treat. So we need to know or try to elucidate that so we make a plan. Some patients who are asymptomatic, though they have cancer, sometimes we say, you know what, it's there, we're going to watch it, it may see it grow, but we don't have to treat it. And it's okay to do that in that person. But if a patient comes in with so much diarrhea from the tumor, then we need to treat the patient. This is an example of a patient that came in with a liver. All those white dots that you're seeing on the side here are all neuroendocrine tumors in the liver. The entire liver is full of tumor. The patient came in because they were losing weight, not able to eat. This is a pancreatic neuroendocrine tumor. We have to treat this patient to make them feel better because the bulk of the tumor. Another patient may come in like this. This is actually a scan of the belly. The gray color that you're seeing here, like a density that's different, is actually all fluid in the belly. Even though this patient does not have much tumor volume, this tumor is located badly in a spot where it is impeding the flow of the gut blood vessels, and that's caused the fluid. And so that person is symptomatic even if it's one spot because of that strangulation of the bowel or the bowel blood vessels. Another patient may come in. On this one, you're seeing a huge mass, which is in the pancreatic tail. So this is on the right side of the last panel. You see a big mass causing pain in the back. This patient needed the tumor to be shrunk, so the back pain from the pancreatic mass is decreased. So patient may come bleeding from a pancreatic mass or jaundice. So many different presentations, many different treatment. Syndrome, which is basically referring to the presentation with the hormones. So on the left side, you see this red color patient. Now remember, patients who are African Americans or not of Caucasian ethnicity may not necessarily turn red because you can't see them turn red, but they feel the warm feeling or a momentary rush, a flush. So you have to go by the history. You don't have to see it if the patient feels it. And so that's flushing that needs treatment to control the hormones. On the middle panel is an example of a carcinoid heart disease. This is a valve that's destroyed by the hormones, and that presents as a heart failure. The person is going to need to have the heart fixed, valves fixed first to take care of them. And on the right side is an example of a rare tumor called glucagonoma. This patient actually presented to dermatology with a big rash, and then also had very poorly controlled diabetes. The CT scan was not done for this. It was actually done because he had a kidney stone, and that showed this huge mass in the pancreas. So somebody put the mass, the rash, and the diabetes together and diagnosed glucagonoma, which is a rare type of neuroendocrine tumor, making glucagon the hormone. And as soon as the tumor came out, you can see the legs and the bottom, pretty much the rash completely resolved. So many different presentation with syndrome. Patients' values and preferences. What is your goal? What is most important to them? That's always the first question to ask. Now, these are hard questions. These are hard questions for the doctors to ask, for the patients to ask themselves. But it's important for the patient to also ask these questions to themselves as, okay, here I am dealing with this. What does this mean to my life and what's important? Now, that helps the doctor also make a good recommendation if you share that with the doctor. Even if the doctor doesn't ask you, please make sure you volunteer that information. Now that the diagnosis is clear, what's next? You've had the basic elements covered. Establish a follow-up plan. What does it look like? Sometimes it's overwhelming the first visit. So maybe not the first visit, but the second visit after you've educated yourself, come up with a plan. Are we going to change this way? Are we going to see every 6 months? Is this a good time? Every 3 months? Is this good for me? Should we be doing something different? Or when should we be doing something different? And also then, do we need to start treatment right now? Can we wait? Now, like I said, there are situations where we wait and there are situations where we don't wait. Should we be getting an opinion at a high volume center? Should we be getting a surgical opinion at endpoint at some point? Ask those questions. What imaging is good for me? What kind of scan is good for me? My tumor is better seen in the CT, a good quality CT, like I said, with the contrast, or sometimes when the tumors are very tiny in the liver or there's fatty liver, MRI may be a better modality. Some patients have bad kidney function, so we can't use the CT dye periodically. We prefer to do MRI. So what imaging is good for my situation? And again, these answers are not set in stone. Depending on the situation, the doctor may feel something else is better for you, but have that communication, ask those questions. Do we need a PET scan every 6 months? Now, this is a question that I get asked often, and the answer is there's actually no good guideline, even for the doctor, to say this is what we need to do. But individualize the plan. Probably PET CT every 6 months is excessive and not necessary in the majority of the patients. But there may be situations if the tumor is growing, should we get a PET CT? My hormone symptoms are increasing, but I'm not seeing a change on the CT scan. Should we be getting a PET CT? Or we know there's a lot of, like it's a cancer in the bone, which we're not seeing on the CT. So should we consider CT maybe once a year, once every 2 years, just to get a sense? So again, this is a question that's reasonable to ask, and the doctor may have a good rationale to do it or not to do it. Again, the guidelines for the doctor is also not clear. It's very individualized in the situation. Then should we be looking at a clinical trial? Is there a new therapy option for me that I should be considering? Is there a need for genetic counseling that is basically trying to look for inherited tendency for this cancer? This is especially important for patients who are young, less than 50 at diagnosis, or they have a strong family history of even other cancers, not just neuroendocrine tumor. There are actually recent studies that say even up to 10 to 15% of patients with pancreatic, there could be beyond what we call the MEN syndrome or MEN1, other genetic inherited tendency that we may be finding. Now, not everybody is going to qualify or be, the majority of the times I tell patients, I don't know why you have this, but if there's a strong family history based on the age, based on pancreatic neuroendocrine tumors with gastrin secretion, there are guidelines now and there's actually insurance coverage. And then nutrition, palliative care, coordination with local oncologists. How are we going to do all of this? What are the other ancillary services that are available that I can tap into? Ask those questions. What can you do to help the doctor? That's important too. Clear communication with the healthcare team. Now, it also expect vice versa. So if the team is not communicating with you, definitely, but we also hope for the patient to tell us clearly their expectations and their symptoms so we can understand better how to treat the patient. Log or track your symptoms. Know your body, understand your body. You know your body best. But if you can't express it or explain it to the doctor or the team taking care of you, it's a little hard. If I tell a patient how much diarrhea you had, if an answer is a lot of diarrhea, that's not very helpful. What does a lot mean? 2 times could be a lot for some patients, 10 times is a lot for some patients. So log or track your symptoms. That helps us make a plan to assess your symptoms. Ask questions and come prepared for your visit. It's okay to ask questions. It's also helpful if you come in, this is what I want to cover during my visit today, at the very least. So come prepared for your visit. It's okay to ask for a second opinion. This is about you. It's okay to do that. Don't be afraid. It doesn't mean you're not trusting your doctor. If it's a rare tumor, you're seeking another set of ears and eyes to look into the situation. And, sometimes I also think, if I look at a patient for 5 years, I'm just looking at one way. I welcome sometimes a different doctor. It's okay for you to ask a second opinion. Know your team. It's a multidisciplinary approach. You may be just seeing the oncologist or a surgeon every single time, but remember there's a whole army behind them. They are operating as a team. So learn about the team, know about the team, even if you don't interact or see them directly. That's important because they're also batting for you. They're on your team. The reality is, I don't know everything. Nobody knows everything. There is a gray zone in healthcare. It's very hard as a patient with cancer to say, why can't you tell me a plan? Tell me what to do. Why is it not clear? But there's always gray zone in healthcare. It's not always black and white, and that's a little unsettling. Now, that doesn't mean lack of confidence. It's a little hard to be comfortable with that gray zone in healthcare. We should be gracious of that, as well as the patients and the family members. Advocate for your peers, patients with neuroendocrine tumor, advocate for healthcare policy, advocate for coverage, advocate for research, participate in whatever you can for the greater good if you have the time and energy, of course. I think this is all the things that I want to convey to our, to the patients, to know you know these elements and you ask these questions. And remember, we are a team. Thank you.